Thank you, Dr. Thompson, and thank you for the opportunity to give a brief overview of our study. TWICH is an acronym for TCD with transfusions changing to hydroxyurea, and I share the honor of this presentation with my co-principal investigators, Barry Davis from the Data Coordinating Center and Robert Adams from the Neuro and TCD Core. Stroke in sickle cell anemia is a huge problem, particularly in pediatrics. It's one of the most severe clinical events that occurs in children. Up to 10% of children will develop a stroke historically. And lifelong transfusions can be used to help prevent stroke but have associated morbidity with their use. Now, Transcranial Doppler, or TCD, has been used over the last 10 to 20 years as a way of screening children to identify those at high risk of developing stroke. And in that setting, transfusions can be used to prevent the stroke, but has the associated morbidity and complications of that treatment. Treating a 3-year-old with chronic transfusions lifelong is a very big undertaking, for example. And our question was, can hydroxyurea substitute for transfusions to prevent primary stroke in children with an abnormal TCD? Here is our schema of our study design. We have a number of patients from around the United States and Canada with sickle cell anemia. They had a set inclusion and exclusion criteria, after which they consented into the study, had screenings, and then randomized either to standard treatment, which was continuing blood transfusions, or an alternative treatment, which was using hydroxyurea as primary stroke prevention. If children were iron overloaded, which most of them were, the choices on the standard arm were to use oral iron chelators, on the alternative arm to use a monthly phlebotomy regimen. And after 24 months of treatment, they would repeat the entry studies. The standard arm had 61 children who continued their transfusions with a goal of keeping their sickle hemoglobin suppressed at 30%. And as I mentioned, iron overload was treated with a chelator. The alternative arm had 60 children. Hydroxyurea was escalated to a maximum tolerated dose, an MTD defined by the protocol. There was an overlap period for the first few months with transfusions weaning before the MTD was reached. And at the time of discontinuing transfusions, a serial phlebotomy program was begun to manage iron overload. There was safety monitoring of the trial through a centralized and masked stroke adjudication committee, as well as an independent data safety monitoring board appointed by the NIH. At a scheduled interim data analysis, which was to be after 1/3 and 2/3 of the participants exited, at the first interim data analysis, the primary statistical endpoint of non-inferiority was demonstrated. This was repeated after a few more patients exited, and the trial was terminated early. And in the final statistical analysis for non-inferiority, it was highly significant with a p-value shown. At the study closure, all of the children moved to the study exit phase, and you can see the breakdown of the two treatment arms. The majority of the children completed the entire 24-month treatment period, including exit studies. There were about a dozen children in each arm that had an accelerated move toward the exit due to the premature study closure. We call this a truncated, and then there were a few that exited from each side. Here is the primary endpoint using a statistical mixed model showing the TCD velocities in both treatment arms. The standard arm with transfusions is the dotted line. The alternative arm with hydroxyurea is the solid line. Here are the actual TCD velocities at each 3-month time point, and you can see that the curves track very closely together, hence the ability to determine and demonstrate non-inferiority. And the intention to treat protocol-derived statistical design showed the non-inferiority as well as a post hoc analysis for superiority with p-values shown. So in summary, we have completed a multi-center phase 3 randomized clinical trial of children with sickle cell. There was full enrollment ahead of projections. The primary study endpoint was achieved. TCD velocities were maintained in both treatment arms, and the non-inferiority principle was demonstrated at the first data analysis. Important secondary endpoints were also collected. There were no deaths or new strokes on either treatment arm. There were 3 events termed transient ischemic attacks that occurred in both arms. There were no new brain MRI lesions, only 1 new vascular progression, and a greater decrease in liver iron on the alternative arm. So in conclusion, for children with sickle cell anemia and abnormal TCD velocity, if they meet the inclusion criteria, which were no prior stroke or TIA, and after a period of transfusions, which we defined as at least 12 months, and without vasculopathy, in this setting, hydroxyurea can substitute for chronic transfusions to maintain TCD velocities and help prevent primary stroke. Thank you.